All right, so inhaled steroids. We're going to talk about inhaled steroids in about 25 minutes. So I'm going to ask again a question just to start with. When you see a kid with croup, how many of you give inhaled steroids? Croup. Sometimes. When you have someone with asthma, how many of you use inhaled steroids as a normal part of your regimen of care? And how many of you discharge them with inhaled steroids? You're supposed to all raise your hands here. Okay, so we're going to go through this, and what we're going to find out is something I think most of you will find surprising with this literature. That in fact, inhaled steroids are as good as systemic steroids in every one of the conditions we use them in. As effective, if not more effective. And so it's going to change your mind a little bit, I think. Will it change your practice a lot? No, I don't think so. One of the reasons it won't change your practice a lot, except for maybe asthma, is a question of cost. If you take a look at how much it costs to give the doses we're going to be talking about, it's fairly expensive, but it's also something that's much easier to do it a different way to get the same results. But I'm going to tell you about this for one of the reasons, simply because sometimes there's a reason to do it. How many of you have seen a child with croup who you've given the dexamethasone to, and they go, bleh! And the nurse goes, so what are we supposed to do now? And you all say, give it to him again. Or you inject it in the thigh. Now that's a really good one. I always love sticking kids in the thigh with something. Makes them hate me forever. So we're going to give you some options for something to think about. We're also going to make you challenge the way you take care of asthma. Even though the Canadian guidelines are really good, I think we can do even better when we go through this information. So the stuff there, basically there's two people in the world who have published the stuff on inhaled steroids and croup. Gail Hood from Australia, who's done a lot of work, and Terry Clausen from Edmonton. And those two people sort of basically almost agree with each other. Australia publishes an article, Canada publishes an article. Australia publishes an article, Canada publishes an article. And they sort of defined it, and then no one follows what they do. So let's ask a simple question. What dose of dexamethasone kilo? Let's ask an Australian.
I give inhaled budesonide.
You give inhaled budesonide. Anyone else? PO, what dose? 0.3 per kilo? Okay. So in actual fact, why did we ever start with 0.6 milligrams per kilo? Answer, why not? That's why we came up with that dose. While it converts from, for pounds, it was this, so why don't we give this dose? Well, in fact, Gail Hood actually showed that 0.15 milligrams per kilo of dexamethasone is as effective as 0.6. And has shown that in kids even admitted to ICUs in Australia, that 0.15 milligrams per kilo is just as effective. So you don't need to give that big a dose. And in fact, if you remember, the dose that you're supposed to give for asthma is 0.2 milligrams per kilo, okay, if you're going to give dexamethasone. So there's no need to give that big a dose. Now, does that make a huge difference for one dose in terms of side effects? No, but we do know that if you give more than the equivalent of 1 milligram per kilo methylprednisolone PO, or prednisone PO, that kids get really wacky. It's been shown that if you give 2 milligrams per kilo of prednisone, they really have behavioral swings, and they go all over the place. They're racing across the ceiling. They're underneath the table chewing on your leg. They don't sleep. And if you lower it down to 1 milligram per kilo, they don't do that, which is equivalent of 0.2 milligrams per kilo of dexamethasone. So if you're going to give more than one dose of oral steroids, that you should be thinking about that. So what about inhaled steroids? Well, as mentioned, Gail Hood said, why don't we take a look at 2 milligrams of inhaled budesonide? And how much does that cost in Australia? No clue.
Less than in Australia.
So they took the nebulized budesonide to 2,000 micrograms total over 30 minutes versus saline placebo. This was number one. At 2 hours, budesonide was better with respect to croup scores, overall disease severity, and degree of stridor. That was 1993. So 15 years ago, it was proven to be effective. Now, medicine's slow. The average time to take a new treatment into your treatment plan is 12 years. So we're only 3 years past what we're supposed to be doing. Gail Hood again, 1995, number 2 there, 80 children, randomized control study of 0.6 milligrams per kilo of Dex, PO, versus 2 milligrams of nebulized budesonide. Symptom improvement in 2 to 3 hours. No difference between oral and inhaled steroids. None whatsoever. You have to understand that 2 milligrams is a quantum leap over what we normally give. You know, I remember when I had some kids about 10 years ago and I was giving Flovent and I was giving 100 micrograms twice a day. And the pediatrician went nuts on me saying, you only give them 50, this is toxic, this is going to kill them. Well, 100's 1/20th of the dose we're talking about here in treatment for croup. So we're talking a much different level of inhaled steroids. And so you're going to get a systemic effect in addition to the local effect when you give that high a dose. The other problem, of course, with nebulized budesonide is, as I become even more attuned since I moved the last 2 years to Toronto, is, as you're aware, nebulizations are a bad thing in Canada. Health and Welfare Canada says you're not supposed to give nebulized anything to anybody. Why? Come on, the Canadians. SARS. Nebulization kills people. It spreads SARS around and gives it to other people in the room and outside the room. So no one's supposed to be giving nebulized anything to anybody anymore in Canada, and in fact, the United States or anywhere else, because of the risk of transmission of disease. How many of you have emergency departments where you're not nebulizing anything anymore? Well, so you're all respecting the recommendations then, I said.
In groups, how about that epinephrine? We should give a racemic epinephrine.
Yeah, we don't do that anymore.
We're not doing that.
No.
That is one of the guidelines?
No, it's not on the guidelines, but nebulized stuff you're not supposed to be doing, and I consistently fight everywhere I work to get nebulized treatments gone. And quite honestly, nebulized treatments have no advantage over spacers with MDIs, quite honestly.
That was the standard treatment.
I know. Well, that's why we're changing things. So, if we go on, we know that budesonide dosing is much higher, so you have to remember that and just get that into your head. And we've talked about the lower dose of oral stuff. So if we go on, British study, a couple of meta-analyses. So how do we take this home for croup? Yes?
The duration of the budesonide nebulized versus like an injection of dexamethasone?
The budesonide, how long does it take you to get nebulized? It takes 20 minutes, right?
In terms of duration of action.
24 hours.
So it lasts.
Yeah. If you take a look at most of the studies, you see that at 6 hours, 12 hours, 18 hours of the benefit, and about 24 hours it starts tapering off. Yes?
What advantage of oral dexamethasone is it has a longer duration?
Yeah, in theory it's supposed to be 36 to 48 hours, I agree. But if you take a look at the studies, that doesn't seem to play out. I mean, I've always thought that in the oral steroids, you were giving them the one-time dose dexamethasone because you're worried about the recurrence the next night or the night after. You're not giving it so much for this one, but to prevent them from coming back. But the inhaled budesonide seems to prevent them from coming back. And so the studies seem to bear out that, yes, it gets them out of your ED, but it also prevents them from coming back.
You just wonder if the vast majority of mild, 95%.
Oh, I agree.
You're really treating 5% with 95%.
I agree. But unfortunately, if you take us like croup is like asthma, there's very, very few studies about return rates in severe. Most of the severe croupers you end up admitting, and then no one looks at what happens to them after the fact in terms of follow-up because you keep them in hospital until they get better. That's why you don't have that. So the two meta-analyses, number 4 from Britain, effect within 5 hours, less likely to require admission. But more importantly, and this is an important one for you to read if you haven't already read it, the Cochrane meta-analysis from 2004 basically says don't give IM dexamethasone. I think that's a very important point to take home. They said inhaled, it decreases length of stay, decreases use of racemic epi, that oral is better than IM in terms of effect. It's not equivalent, it's better. And that oral is equal to nebulized. So the Cochrane meta-analysis comes out and specifically says, don't give IM dexamethasone. So if your child's throwing up, the treatment recommendation is nebulized treatment, not an IM injection. Okay, so that's the take-home message for croup. What about if we combine them? Well, there's a couple of articles here, number 6 and number 7, one from Australia, again, one from Canada, because like I said, they can't do one without the other. And they both come to the same conclusion, that adding inhaled budesonide to oral dexamethasone doesn't give you any extra bang for your buck. You've maximized what you're going to be able to achieve, so give one or the other. So it just depends where you work, what the cost is, what the child's going to cooperate with, whether they're throwing up or not, what you're going to choose. But they are equivalent in immediate action, discharge rates, getting people home. Yes? I can't remember the last time I gave racemic epi. If I had to give it, then you're going to have to give it inhaled. Yeah, you have to, but I mean, I can't remember the last time I gave it. When I give inhaled steroids, I just give a lot of puffs. I don't use nebulized form because that's the way I give it. And I can't remember the last time I had to use racemic epi as a result. It's changed the way I do things.
So what about a child on the age of 2 or a meter?
You just take the aero chamber with a mask, you plunk it on their face. And you just,
How many times do you?
and you just give a puff, and you let them breathe 2 or 3 times. It's like I do with asthma. And I just use metered dose inhaler, and it works just fine. Really? Yep.
Is there a reason why the IM dexamethasone was not as effective as the oral?
No, there wasn't any reason. It's just in the studies, it didn't turn to be effective. I don't know whether it was where it was given or what or why. It's just that in the meta-analysis, it turned out clearly that the clinical response rate for the 2 or 3 days after discharge wasn't the same. All right, asthma. Now, yes?
So if you're going to use puffers for what kind of dose are you using?
When I use it in children, yes. I take the 250 flow vent, sure. And I just give them 10 puffs.
And that's equivalent more or less to
2 milligrams of nebulized.
So 10 puffs?
Yeah, 10 times 250 is 2,500. I told you the doses were a quantum leap of what you're normally thinking about, okay? And you have to get your head around that, okay? But that's what works. And in fact, you can see, it's surprising, and I'm sure you see the same with the nebulized stuff, I see within 5 or 6 puffs, they start to improve. It's not like 2-3 hours down the road. They start improving.
What about oral dex? Because I know the studies say it kicks in around the same length of time, but do you see that same effect with oral?
Not right. I don't see the immediate effect I do with that. My clinical experience is that inhaled works faster than oral. Is that your experience? I see it literally within the 5th or 6th puff, I'm starting to see an improvement.
What sort of,
Yeah, go ahead.
what sort of pathophysiological basis for that would you, for an inhaled steroid working?
Honestly, if you take a look at the way steroids work, they're not supposed to work that quickly. I mean, there's supposed to be a time for resensitization, and there's supposed to be about a 60-minute time frame minimum. So I can't explain, but I watch it happen. I honestly couldn't tell you why. I honestly couldn't tell you. I know what physiologically it's supposed to do, but I can tell you what happens to the patients. Yes?
I was unaware of any recommendations regarding nebulized treatments. And you're saying you just don't do nebulized treatments of any kind anymore?
Gosh, I tried to do almost none. I mean,
And why is that? What does that
because in Canada it was recommendations because of SARS.
What does it do, though?
Because when you have a nebulized treatment, you have vapor droplets, and it transmits disease. It's also been my experience personally over the years. From the yeah. When the patient breathes out, the virus is in it, it spreads the virus.
So you have a mask on everybody after? I mean, what I'm wondering is, so you don't want people breathing these droplets. So
Right.
you put a mask on every person who has an upper respiratory.
Yes, we do.
Little kids even?
Yes, we do.
Really?
Yes.
That's what I thought was what you were saying.
Yes, it has. When we went through, for people who were around in Vancouver, Toronto, and certainly in St. John, you came in with a fever and a cough, man, there was a mask at the door for you to put on. Well, we still do it.
So like an 18-month-old kid with a...
We still do it in the hospitals I work in.
They won't even provide us with the standardized equipment that they suggested and not, special masks.
Really?
Things for intubation, they said it's not cost effective, you can't have it.
Gosh, I'm still using the masks with the shields and everything.
So does your staff wear masks? Do
No, but they do it when they, I can tell you the patients that come in with cough-related illnesses are all put in separate rooms. They all have their masks on, and they're treated that way. Yep. It's actually, they're very cooperative. It's remarkable how well they stay on. You come and see these little kids, and they got their little masks on, and they...
Does the hospital supply the spacers, and can you give
Yes.
them to the patients?
The hospital supplies the spacers every place I've worked. And in most hospitals, yes, the spacers go with the kids or with the parents. Yeah. Yeah, they do. Yeah, they're $40.
You make one for 79 cents out.
Pepsi bottle. Yeah, I agree. All right, so asthma. So let's get on to asthma. If you remember that there's a phenomena about asthma. When you're treating acute asthma, more is better, right? There's no such thing as an end dose of salbutamol, right? Ventolin is Ventolin. You just give it till you give enough. And you know, when they start shaking, you have to just remember when they start shaking, they don't shake more and more. Once they get a little tremor, that's all they get. They don't start getting, you know, like a Los Angeles earthquake and fall off the bed. That doesn't happen. They only shake a little bit, and you just keep going. They don't shake more. Don't worry about it. And in fact, the little kids who are really tight, you know when you get a response, because at first, they don't get shaky and they don't get tachycardic because they're too tight. When they start getting tachycardic and shaky, it means they're getting systemic absorption, means the drug's getting into their lungs. So you're doing what you need to do. So it's a great thing to know they're absorbing it. Now, if you use a little MDI without the spacer, they get tachycardic really quickly because they get absorbed through their tongue. It's called a tonsillar wash. That's why you need the spacer. And it's a great way to judge what you're doing. So the stuff that came out with inhaled steroids came from Uruguay, of all places, and showed that, you know what? If you're just as aggressive with inhaled steroids, in addition to your Atrovent and your Ventolin, you get even better results. So study number 8 was the first one, 2003. There were 3 arms to this study. Albuterol and Atrovent, 4 puffs each every 10 minutes. Versus albuterol and Flovent, 4 puffs each every 10 minutes. Versus albuterol, Atrovent, and Flovent. Okay? Now we're talking, that's 12 puffs every 10 minutes. So, improvement in baseline pulmonary functions. If you just gave the albuterol and Atrovent, 126%. If you gave the albuterol with the Flovent, 149%. And you gave all 3, 189%. With huge decreases in admission rates for the triple combination therapy. The admission rate for albuterol and Atrovent alone was 25%, but if you gave all 3, it was 11%. That's a big drop in admission rates. So then there was a meta-analysis done by the same author, Rodrigo, number 9, which is very convincing. 17 studies, 470 adults, 663 kids. Inhaled steroids decrease admission rate without a doubt, especially if several doses are given with less than 30-minute intervals. You know, when we give inhaled steroids in acute asthmatic, you might give them some Flovent, you know, give them 3 or 4 puffs once, because, oh, they should get inhaled steroids, give them some prednisone or whatever. This meta-analysis has shown that if you just hit them regularly, just like you do with your albuterol, every 10 or 15 minutes, you just keep going, that you markedly improve your discharge rates, you markedly improve respiratory function over anything you can do with just albuterol and Atrovent. And that this is the way you should be treating asthma. This is a big change from what most of us do, okay? So there was an article there by Dr. Susanna Shu, who some of you know from Toronto. She tried to refute this, but she did the wrong study, unfortunately, because she basically gave the one-time dose, 2,000 milligrams of budesonide, or was fluticasone, but she only gave it once. And she found no difference in admission rates or discharge rates because she didn't do what Rodrigo and all the meta-analyses have shown you have to do, which is give it fast, frequently, and a lot of it, just like we do albuterol and Atrovent. And so you might want to take a look at this. It's no big deal to put a 3rd puffer down beside your spacer, you know, and just puff away, because it's no change. For where I work, when I was in St. John, the RT was there 24 hours a day. They just gave the puffs. When I work in a small hospital, because now I do a lot of small community hospital work, that's what I do now, it's either me or the nurse. And the nurse does the little puffs. And quite honestly, by the time they get better a bit, the patients do it. So it's not time difficult. And I have found that the puffer with the spacer works far better than the nebulizer in a really sick patient anyway. I had a girl come in my shift about 3 weeks ago when asthma was really bad, who was near death. Her eyes were glazed over, she wasn't talking to me, she was sucking in air, and you couldn't hear any air entry. So she was getting close to, I want a ketamine. I want ketamine, I think she was saying. But in fact, I just gave her a puff, literally every 15 seconds because I just went albuterol, Atrovent, Flovent. Went back, albuterol, Atrovent, Flovent. And in 10 minutes, she was awake and talking. It was absolutely remarkable. She had a total of 26 puffs in the first 20 minutes she was there. She was awake and talking. No, I give one puff, stick it on their face. And in adults, you just use a mask on the end of your chamber just like you do in kids, because they just have to breathe it in. They don't have to hold their breath. You have to wait for that puff for 60 seconds for it to recharge, right? So if you're going to give it every 30 seconds like I do with albuterol, I have 2 of them, because you have to change them. Because you have to give it the 60 seconds, otherwise you're just giving them Freon. So you can't use any one puffer more than every 60 seconds because it takes that long for the cylinder to recharge. So you have to have your puffers lined up and go through them. But it is much more effective than a nebulizer for someone who's really sick.
Has anyone ever looked at blood levels of or anything
No.
in comparison on puffers versus nebulized?
No,
The reason I'm asking is because when we give, and we still do the nebulized medication, we're giving 5 milligrams.
Yeah.
So that's to be compared to 100 micrograms per puff. So you're basically saying that's equivalent of 50 puffs.
No, it's not. No, it's not. It's been shown very clearly that 6 puffs from an MDI are equivalent to 5 milligrams nebulized.
By clinical outcome or by actual?
By everything. Multiple measures, because the droplet size is so big with the nebulizer that most of it doesn't get to the lungs. And it's been shown very clearly in literature from the 80s that 6 puffs of an MDI is equivalent to 5 milligrams. And I can give 6 puffs a heck of a lot faster than you can give 5 milligrams. So by the time you get through your 15-minute nebulized treatment, I've given them at least 15 to 30 puffs, which means 5 times what you've given. I don't have to. I really don't have to. They just, if you use the nebulized, if you use the MDI with a spacer and you just bang it in like that, you don't need to. And I want you to take home from this that inhaled steroids are clearly additive in this process, and if you want to read that meta-analysis, it will change the way you practice. All right, we're into break time, so I have to skip on here to another thing, number 12. There's an article that says if you give 4 puffs of the 250 Flovent to kids twice a day, which most pediatricians will be like, you can't do, it's the equivalent to giving them oral steroids, and so you don't have to give them oral steroids.
So, but if it lasts for 24 hours, why are we doing a BID?
Why are we doing a BID? If you want to give it all at one time, you can. I'm just telling you what the study shows.
Why not give them oral steroids? I understand the case that every night kid has trouble with oral steroids.
I'm not telling you to not do it. I'm just telling you that they're the equivalent.
They're equivalent.
Okay? I mean, the studies have shown, for this purpose of this talk, that we're talking about the equivalents here. COPD, again, 2 milligrams, number 16, 2 milligrams budesonide QID, 2 milligrams, 3 times 3 days, then 2 milligrams each day was equivalent to giving prednisone 60 milligrams PO each day. So you can, with high-dose inhaled steroids, give the equivalent of oral steroids in certain people. Why might this be important? Well, it means if you have someone who's having difficulty taking food or whatever, and you don't want to intubate them, they have BiPAP or something. Well, they can't eat on BiPAP, but you can give them budesonide on BiPAP. And then we don't have to stick an IV in them and give them in steroids. It's a moot point. It's just to show you that you can do it. Finally, remember we talked about yesterday about not taking care of statins, not giving it to the people who should get it even though no one should get it? You remember that talk? So this is another study, number 17, looking at patients 90 to 360 days after hospitalization. Those with inhaled steroids, 3.3% mortality versus 6% in those without. Absolute mortality over the age of 65, 11.7% versus 13.1%. So you should be making sure that your patients are inhaled steroids if they're COPD patients. It saves lives, it decreases mortality. The problem is, where is it? If you take a look at number 13, let's skip back to that just for 1 second. Sedulka showed that just like with statins, patients don't get prescribed their inhaled steroids. Asthmatic patients discharged from the ED, 38% follow-up within 6 months. Funny, that's about the same percentage of follow-up of people who are discharged with unstable angina. 40%. 22% of those with follow-up got inhaled steroids at that visit. Only 13% of people discharged from the ED got inhaled steroids. I would assume, certainly in Canada and Australia, that almost 100% of people are getting inhaled steroids at discharge. But it's something that we really need to work on. Now reality sets in. So I've told you all the wonderful things about inhaled steroids. Here's the reality in the United States. Flovent 50 mics puffer is $91 per inhaler. And the 250 mic is $193 per puffer. No wonder no one takes it in the States. So what's the cost of inhaled steroids in Australia?
It's all subsidized from the pharmaceutical benefits spend.
Right.
You don't see the true cost.
So you don't see the true cost. Who knows what it is in Canada? Yeah, it's around 70 or 80 for the 250 or the 125. They're the same cost. So there's no real reason to have the 125. And the Flovent 50 for kids, which, as you can see, is a really tiny dose, is only about $45. So it's about half the cost of what it is in the States, but it's still fairly prohibitive. And if we're going to start recommending higher doses, boy, the cost jumps up really quickly. So it might be very effective therapy in the emergency department. And in fact, I would strongly recommend you think about it for both croup and asthma in the emergency department. But you have to remember that you can't whack them with big-time doses at home because of the cost, and that oral steroids are going to continue to be used, and you can use the regular doses for inhaled steroids at home. Any one of them. Any one of the inhaled steroids is fine. Any questions?
How much does the budesonide cost? Is it pretty expensive?
Budesonide in the emergency department in my hospital is $25 per dose. Yeah.
You keep on mentioning Flovent, but there are other inhaled.
There are other, and it's just because that's the one I have available here. There are multiple other ones that are just as, which are cheaper, yes. In fact, Dexamethasone, which is generic and is, in fact, you can get the Dexamethasone one. You have to give twice as much as the Flovent. And the Dexamethasone was taken off the market in Canada for a while. A generic form is still available. And an inhaled one of 250 mics is, I think, $20. It's much cheaper. I agree. Because the same company that produced Beclovent came out with Flovent to protect their patent. And so removed Beclovent from the market. And it took 5 or 6 years for a generic company to develop it and put it back on the market.